so much for having me. I'm excited to be here. And thank you for that introduction. And I have my most favorite t-shirt on right now that says everyone watches women's sports. So that's how much of a super fan I am for women in sport. So I'm excited to be here to do this case presentation with you. So it's a scar-focused electroacupuncture for lumbopelvic pain and stress urinary incontinence in a postpartum athlete. You already heard a lot about me, so I will not share any more. So why did I choose this case? So for me, this case is really interesting and cool, and it blends what I do in my practice, which is pelvic health, sport physio, and neurofunctional acupuncture, electroacupuncture. I just think it's a really neat example of how we can combine all of those things to help create meaningful change for somebody who has a complex history. And to me, this case highlights how well electroacupuncture can be used to support recovery as an adjunct treatment for active women who are postpartum, who experience pelvic health symptoms, and have complex history. So this was clinically interesting and challenging because it was an individual who was quite active throughout their life and rehab, and they were still struggling. And the surgical history is quite complex and interesting. And so this case was, for me, really neat to see just how capable the body is in adapting, despite even the significant surgical history, which I'll talk more about in a bit. And so what I'm hoping to explore together today is just, again, sharing what I think is a cool case that isn't that uncommon for me to see in my practice. This one's a little bit more unique with the surgical history. What I did, how it made sense based on the person that I was working with, their history and their anatomy. And that even though strengthening and active rehab is a huge part for a postpartum athlete and needs to happen in many cases, electroacupuncture can be a really helpful adjunct to support their recovery. So format and framing, we went over this just a little bit, but this is a case reflection, not a how-to. I'm going to share what I noticed, tried, and questioned, and then we can do discussion and questions at the end. Okay, so the individual, the person, it's a 45-year-old woman who works full-time in healthcare, is at a desk job. She's a mom of 3 kids. Her activity level, sport, so she used to be quite active doing powerlifting pre-hernia surgeries. After her hernia surgery, she feels comfortable doing some Peloton strength classes and riding the Peloton bike. She tries to run and cycle when she can, when she's not having a flare-up of back pain, and again, walking when not dealing with back pain. Prior to surgery, she was training about 6 hours a week. And then after the most recent surgery, she can do 1 to 2 hours a week on a good week. A brief surgical history, because I'm going to go into more detail a bit later. She has had 3 C-sections. Those were for 3 pregnancies, so 2005, 2008, 2013. She had an appendectomy in 2019, a ventral hernia repair in 2020, and then she had to have a repair of that failed hernia repair with mesh and a cholecystectomy in 2022. And so that's the surgery where she felt everything fell apart for her. What's most important to her is that she wants to get back to feeling like herself again. She feels like she doesn't know how to move her body anymore. And I would say that's really common. Women postpartum, especially after multiple pregnancies, that I see is they just feel like they're not connected to their body. They don't know how to move it. It just doesn't feel like theirs anymore. So her goals, she wants to move without pain and restriction. In our first appointment together, she had given up the idea of powerlifting or lifting heavy. So she just wanted to be able to do some weights without flare-ups, and gain strength because she felt like she lost it all. So I'm just going to move my thing here. These were her presenting concerns. So this is the pain chart or injury chart that I use in my charting. And we have 1, 2, 3, 4 pain areas. So 1, her core felt very weak. So this is still her subjective. Her core feels very weak after her most recent surgery. She does experience stress urinary incontinence with lifting, with sitting down too quickly, sneezing, running, or coughing. She used to only have stress urinary incontinence with lifting, but now even if she goes to sit down quickly, she will have leaking. And she does experience pelvic pain with intercourse. She describes it as a deep pain, and it's quite sporadic. She also complains of right hip pain and low back SIJ area pain. So that's over here, that will radiate down her leg. She describes it as her SIJ going out with squatting, and then the back pain will start. And this is when she does squatting for exercise. So she feels like a sharp pain, elastic pain in the back when she goes up and down in her squat. And then she'll get this sciatic type pain, as she describes it, into her hip and around the front, in her low back and down her back leg, or down her leg, sorry. She has been doing, like, throughout, for years, she's been doing chiropractic care. And recently her chiropractor had told her that her glutes were not working, her core wasn't firing, and her sacroiliac joint was not being stabilized. And that's why she sought out physiotherapy. Her low back, she'll feel it in her hip after long days of walking, or even after 30 minutes on the Peloton bike. And she does get a numbness and tingling into her toes. This she describes having after a chiropractic adjustment. She feels unstable to bend over and put on a sock. And her first episode of this kind of pain was 14 years ago. And I should say I worked with her in 2020, early 2025. And then more recently, both ankles are super tight and sore. And that was in the last 6 months. And she was diagnosed with posterior tibialis tendonitis that she experiences with running. And what I want to say is I'm going to spend a lot of time actually on the history and the assessment, because I think the details are important. And that is how I do it in my practice. So bear with me, because there's going to be a lot of information here at the front end on this. Okay. There we go. Okay. So, and then other relevant health history. So I will ask about menstrual cycle. And so for her menstrual cycle definitely was an area that we talked a bit about. So she does get symptoms with her menstrual cycle, and it's irregular. So she describes her cycles as being anywhere from 21 to 35 days, which technically is within the normal, but for her, this is what she describes as irregular. And her bleeding days would be long, like it'd be long time bleeding and heavy bleeding. So the heavy bleeding is new, and the length changes in the cycle is not new for her. And she does notice an increase in symptoms with back pain, a dragging feeling, constipation, irritability, and poor sleep when she has her bleed. And she feels more susceptible to flare-ups at this point. So her hip and back pain, her last flare-up was right before she got her period. And then, as I already said, her sleep, she'll sleep 7 to 8 hours, but still feel exhausted. Activity, it has shifted quite a bit, but she's trying hard to stay active. And then other health information. So she has been anemic before and taken iron supplements, but now she's within the normal range. She has had to have B12 injections, and she is taking fiber and magnesium plus increased fluids for constipation. This is relevant because constipation can affect your pelvic floor function. Okay, and then the surgical history, which is really interesting and important. So she had 3 C-sections. In her first C-section, she had a surgical site infection. So she had to have 8 weeks of antibiotics and wound packing. And if you've ever had a C-section or known someone to, you know that's tough to go through for sure. She had an appendectomy in 2019, ventral hernia repair in 2020, then repair of the failed hernia with mesh and a cholecystectomy in 2022. And since this surgery, everything has been worse. So she was powerlifting, and she would have episodes of back pain, but she felt like she could bounce back. Before this surgery, she felt like she had abdominal muscles and she could feel her core prior to this. And since then, she doesn't feel connected at all and feels quite weak. It was quite a bad recovery. She was told it would be difficult. She ended up having 2 years of post-surgical pain, experiencing a tearing and burning pain. She ended up getting a CT scan to see why that might be, and was told that she had quite a few adhesions in her abdomen. She did say she also had diastasis rectus abdominis, which goes hand in hand with the hernia. So hernia will be when you can actually see organs coming through, and a diastasis rectus abdominis is a thinning of the fascia along the linea alba, which we can see with pregnancy and postpartum. She said her hernia was fairly large, so when she contracted her abs, she could see it. And it's important to know that during her surgery, she did not have the posterior rectus sheath repaired. When we look at research from diastasis with Diane Lee and Paul Hodges, there's some really good research showing that if you repair the posterior rectus sheath, it will you'll have better tension across the linea alba, which will help with that control through the pelvis. and core. And so she did not have that done, unfortunately. And she cannot have another surgery because she has mesh. So she did have a consult with a plastic surgeon who said, we can't do anything, we just leave it alone. So her experience of the recovery was not great. It took her 4 weeks until she could sit up. And then she still had pain. She couldn't lay flat because she couldn't get back up again. And then she was with that, even though she was still cleared to lift at 3 months. And then it took about 15 to 16 months before she could bench press anything without a searing pain in her abdomen. So early clinical questions and thoughts. So I'm wondering, is there a systemic influence? Because we have the menstrual cycles, linked symptoms, we have poor sleep, supplements from the naturopath, the history of low iron, possibly into perimenopause with age and the menstrual cycle changes. Is there a metabolic contribution? Again, with the low iron and B12, the fatigue reported, does she have low energy availability? So she's not eating enough, which is common in the perimenopause phase as well. When athletes start to gain weight, they'll restrict to try to not gain weight. And so we do see relative energy deficiency around that time. And then how might perimenopause hormonal changes be influencing the pain and the pelvic floor symptoms? So is it influencing her exercise tolerance? What about the tissue health, the connective tissue health with hormonal changes? Her stress urinary incontinence. So she didn't have vaginal deliveries, so there's no birth injuries. And not that that's the only reason you have stress urinary incontinence. It's not. But there's genitourinary syndrome of menopause, which can be you can have incontinence from hormonal changes. And so we want to consider, is that why this person might be having stress urinary incontinence? And then what role might the abdominal surgery history and pregnancy history play? So I'm thinking postural changes through 3 pregnancies combined with the surgical incisions from the C-section. How's that affecting motor control, muscle recruitment, movement patterns? What kind of compensation patterns have been adopted that aren't serving anymore? And then we also have the understanding that the posterior rectus sheath was not repaired. And so how is that playing into that load transfer, especially into single leg tasks? What does her abdominal look like and how is the scar? So I'm curious about the connective tissue changes and the quality of the connective tissue in the abdomen, and then also scar mobility and sensitivity. I'm not thinking she's deconditioned at this point because she's been training and has made an effort to keep up a level of activity. So I'm wondering, are we dealing with true muscle weakness or not? And then is there nerve entrapment or sensitization because of the abdominal surgical incisions and the scar? I just threw this up as a little refresher. For abdominal wall incisions, we can see the anatomy here. So we're looking at C-section scars are not all of them, but most of them are quite low. And so that's in the territory of the anterior primary rami for L1 typically. And then if we have the other abdominal incisions from appendectomy and the cholecystectomy and the hernias, we're spanning quite a few spinal segmental levels. And then we have the peripheral nerves as well. So C-sections, again, are quite low typically, and that's in the territory of the ilioinguinal, iliohypogastric nerves, which innervate transverse abdominals and internal obliques, so important muscles in the core. So there's other peripheral nerves that can be affected as well from pregnancy and surgical scars, but those are just the more common ones. So in a session, in an assessment, or when I'm working with someone, these are really the 3 questions I'm trying to answer. And I try to have a sense of what the answers could be before I do the physical assessment. So why this person, why these symptoms, why now? At this point, I'm thinking this person because of their history with the pregnancies and the surgical history. And just that last one was the straw that broke the camel's back. So that's why now potentially she was compensating and her activity level was keeping her functioning quite well. She was already experiencing episodes of back pain, but could recover and didn't seem to be limited by it until this last surgery, which also was quite a challenging recovery. And then these symptoms, in the slide before that talked about that. So whether there's inhibition, nerve entrapment, et cetera. And so now from my physical assessment, I want to figure out if those things are there. Okay, so what did I focus on? So this is what I focus on. So I do like to do a movement assessment. And in this case, I looked at a posture, squat, their gait, single leg stance, and a single leg squat. Sometimes I do a quick lumbar spine, just range of motion, just to get a general sense of what might be aggravating or not, and also just general range of motion that they have available. Hip range of motion, neuromotor recruitment, in particular of the hip muscles. Core testing, so an active bent leg raise, an active straight leg raise, and then diastasis rectus curl up testing with and without cues to connect to the core. Breathing pattern in different positions, coordination of the core. So the core testing and the breathing pattern and coordination of the core all go hand in hand for me. I'm looking to see at how they're connecting to their diaphragm, pelvic floor, and transverse abdominals. And then I want to look at scar mobility and sensitivity, and also the abdominal wall visual inspection, but then palpation of the linea alba, given the history with pregnancies, diastasis, and hernia plus surgical repairs. So that's why that was important for all of those reasons. And a lot of this hasn't been looked at for this person as well at this point. So needed to do very comprehensive assessment to make sure that whatever I did do for treatment or recommend was very specific to this individual. So at this point, what was I trying to rule in or out? I was trying to figure out how much of the dysfunction that was present was because of like core coordination versus the connective tissue, scar adhesions versus movement patterns or compensations versus like true core weakness. And then where would I start with treatment? And there were no red flags at this point. Okay, so the key findings in the initial assessment. For the gait assessment, the right was worse than the left, but there was poor hip extension, an early heel rise, and lacked any kind of trunk rotation. In the squat, there was a lot of trunk flexion early on in range, pes planus and their feet bilaterally. And even just with a body weight squat, she reported feeling low back and SIJ pain. And she wasn't able to go below about 80 degrees without symptoms. Her single leg squat was a challenge. She had very poor control through her hip, and you could see that with the knee diving inward, hip internally rotating, and she had poor balance with that. And I didn't do increased reps because that wasn't going to tell me anything more helpful than what I saw just with one repetition. Posture. So she had a flat thoracic spine, and then her feet, again, pes planus bilaterally. When I looked at her abdominal wall, she had significant stretch marks throughout, and they were most noticeable over the midline, over the linea alba, just above the umbilicus, which is around where she had her hernia as well. So for core function, active bent leg raise and active straight leg raise, there was pelvic rotation with lifting both legs, and it didn't change with any compression on the pelvis. Her breathing pattern was apical, so she's breathing up into her chest, and she had decreased lateral costal expansion. And I looked at this in standing. And that's important to me because in order for the core to work well with the pelvic floor and the transverse abdominals, we need to see that diaphragm excursion happening. And that happens most when you get that lateral costal, that bucket handle movement in the lower ribs. And so if there's an apical breathing pattern just in standing without any movement or exertion, then we're not getting that diaphragm moving well, and that can impact how well they're connecting to pelvic floor and transverse abdominals. I do an external palpation of the pelvic floor, so that's just medial to the ischial tuberosity. You can feel the pelvic floor there. I like to look at that in standing and in crook lying, usually at the first appointment. And when I feel that in standing, also I'll palpate the abdomen, the lower abdomen at the same time. And there was minimal excursion. So what I'm like hoping to see is when they breathe in that you get excursion through the transverse abdominals and the pelvic floor. And then on exhale, you can feel that lift gently. But there really was very little movement in the abdominal wall and the pelvic floor with a regular inhale. And then I will also just sometimes do a quick, most people know what a Kegel is or what they're trying to do when you say Kegel. And so just check this quickly in crook lying. And she was able to connect to the right muscles. And just, I'll often have them tell me like what they're focusing on doing. And yeah, so at that point, I knew she could connect to the right muscles, but in standing, putting it together with the system, it wasn't happening automatically. And then the curl up test is good for diastasis. So just having them lie in crook lying and tuck their chin and just kind of roll and lift their shoulders up. And then I'll palpate along the linea alba and looking for separation, so distance between the rectus abdominis muscles, and then also for any tension along the linea alba or lack of tension. And so here I have 2-finger distance above the umbilicus, 3 fingers at the umbilicus or just above the umbilicus, and then 2 fingers below, and that's kind of halfway below. And there was mild tension throughout. So there's nothing like major there for me at this point. That's helpful just to test and retest moving forward to see if when we do intervention, is it changing anything with that recruitment pattern? And so I'll also do sometimes a core curl up. So you can do a core curl up, same test, but cue different core recruitment strategies to see if that changes anything. So in this case, I just asked her to do a Kegel with the breath and it improved tension along the linea alba. So I felt like there was more tension, and then the distance stayed the same. We had poor hip flexion range of motion and internal rotation, the right worse than the left, and neuromotor testing. There was decreased hip flexion and abduction, right worse than left. I did not assess the posterior chain in the first appointment just because of time, but that would be something that would be great to have. And then abdominal wall palpation. So I already mentioned about linea alba. The C-section scars, so there's 3, she had 3 C-sections. It was sensitized throughout and it was hard to lift and roll. So I try to lift and roll the scar, see if I can do that, and then how uncomfortable it is. And the inferior aspect of the scar, felt like more adhesions to me. All other scars were sensitive and didn't have good mobility, and the tissue was thickened as well. And then this is just like a quick, here were the scars that I assessed. So after the assessment, I don't really think my thinking changed too much, but I just had a better understanding of the status of the abdominal wall and the connective tissue and muscle function. So there were quite a few adhesions, there was sensitivity, poor recruitment, definitely not stabilizing or controlling through the lumbopelvic with any kind of load, which is functionally affecting the lower extremity kinematics, which you could see in the squat, in the gait, in the single leg squat. Up in priority, I wanted to make sure that I taught her how to connect her pelvic floor, diaphragm, and transverse abdominals. And this was because of the inhibition and poor recruitment, as well as her history with the pregnancies and abdominal surgeries. And so I use something called the piston system, which is teaching them how to coordinate the diaphragm, pelvic floor, and transverse abdominals together with breath. And then we put that with movement. Questions that came up for me. I was curious, how much tension could we get across the linea alba, because there was the posterior rectus sheath was not repaired, so I didn't know whether we could change that very much or not. How much were the adhesions and the sensitivity and inhibition of the abdominal wall playing into the poor coordination and movement patterns? How long would it take for changes to happen with just a movement approach? How much abdominal muscle weakness was actually present? And then what would be the response to active rehab, and what would change or happen with adding in electroacupuncture treatment? So initially, as I mentioned, we did the piston breath and put it with movements to teach how to dissociate the pelvis from the thorax, and working on lengthening the pelvic floor and getting those lower ribs moving. Starting in crook lying, standing, and then moving into squats. And in the first session, we did trial squat under a 35-pound bar and did 4 reps, no pain in the first appointment. So that was already a big change. And that, to me, reinforced the need to do motor control and active rehab for sure. And then I taught self-scar massage. So I was aiming and hoping to influence the coordination and motor control on the inner core unit. So that's the pelvic floor, transverse abdominals, and diaphragm. Hoping that we would change tolerance to squatting with load, and change the stress urinary incontinence. and ideally having the client feel engaged with their core and body. She felt disconnected from her body. So I wanted to give her things that she could reconnect with her body and feel empowered so that she didn't need me to do anything for her. She had the tools to be able to go and work on that. And then in this first appointment, I did not do electroacupuncture, but I did introduce the concept of using it for scar treatment at the next session. So the overall treatment goals were to decrease the scar sensitivity and increase its mobility, learn the PIS strategy and put it into movement, strengthen these movement patterns into single leg, because that was where there was quite a bit of challenge, improve the gait pattern, engage in progressive core and hip strengthening program with the new movement patterns, and ideally get her back to lifting without pain and stress urinary incontinence, resolve that incontinence, and resolve the pelvic pain. So 2 weeks later, she came back and she was squatting a 45-pound bar. She did have some SI area pain, but it resolved and was manageable, and she wasn't getting anything down her leg. She did notice that she would clench her glutes a lot, her pelvic floor muscles and her hamstrings in standing. And she was feeling more connected to her pelvic floor laying down versus standing. And that's really common when we start this. There's usually a position they feel better than others. A kickstand deadlift she could do. So we still have that single leg piece that's a challenge. And then there's just some other, we moved into some other core strengthening things like the 4-point hover, where she could connect to her lower abs. And her squat was getting better. So she could do a bodyweight squat below 90 degrees and had no pain. And she reported that that felt really easy. And her single leg squat still wasn't good at this point. Hip range of motion still limited, and neuromotor testing, hip flexion was better, but her hip abduction was not good. And the C-section scar was the same. So takeaways here, I had more information about her core function. So she definitely had poor connection to those lower abdominals and some weakness. She tends to grip the posterior chain, poor single leg control at the hip, but we had improved squat depth and tolerance to load. So that was really positive. Okay, so now why we're all here, the electroacupuncture piece. So why was I thinking electroacupuncture for scars? So C-section scars and abdominal surgical scars can cause nerve entrapment, nerve injuries, sensitivity, and muscle weakness and persistent pain. So any surgeries below the ASIS there is a risk of injury to the ilioinguinal and iliohypogastric nerves. And as I mentioned already, these nerves, so that's down here, these nerves innervate the transverse abdominals and the internal obliques. So you have the potential nerve injury, nerve entrapment effect, and then you also have the changes to the connective tissue and circulation in that area. So I was trying to address the sensitivity of the scar and the mobility. Those are two outcome measures that we can use, and they were positive. So there was poor mobility and there was a lot of sensitivity. And then we also had the poor connection to the core recruitment, in particular transverse abdominals and pelvic floor. And that you can test with even just in standing, the movement in standing, plus the person's ability to connect and recruit those muscles. So at this time, it was appropriate for me because it was based on the client's history, the assessment findings, and electroacupuncture, acupuncture, no scar treatment had been done. And also my clinical experience. So I do use this modality a lot to treat abdominal scars, in particular C-section scars in my practice. The things I'm looking out for to know whether it's okay to treat a scar really is that it's healed. So these scars were all old, and that the skin looks healthy, and that the person is comfortable having acupuncture done. So the first time, so this is not this person, this is a picture of someone else, but you can see it's a nice demonstration. So the first time I just threaded on the top of the scar and did low frequency for 10 to 12 minutes. And immediately after that, we had a change in hip range of motion. There was better hip flexion and internal rotation, and neuromotor recruitment of hip abduction was better. A month later, she came back and was saying that after the electroacupuncture, it felt a lot easier to relax her pelvic floor and hips. She had significantly improved her squatting, doing 145 pounds. She was still feeling hip and low back pain, but it was not a flare-up. And she told me that she used to have to wear a back brace and knee brace to squat 100 pounds, but now she doesn't need to. She feels the pelvic floor is becoming more automatic until around 100 pounds lifting, and then she has to be more conscious about it. And all around, she's feeling good. At this point, she was still feeling some discomfort around the front of the right hip when she was going down in her squat. Sorry. And then on the assessment, we still had the tightness in the hips, so decreased flexion and internal rotation. Again, that neuromotor inhibition of the hip abduction was present. We did another electroacupuncture treatment. This time I threaded along the superior aspect. I did try to thread along the inferior aspect, but there was like a burning pain sensation and it did not go away. So we left the bottom alone this time. And I added in bilateral GB29, so TFL and glute med for electroacupuncture, and did low frequency for 12 minutes. And again, we had a change in hip range of motion and neuromotor recruitment afterwards, and that feeling of being able to relax easier. And this is another picture. This is not the same person, but threading under the scar on top and then just along it, so perpendicular to it underneath, and then just some hip points. So a summary of the intervention that occurred. So over the 3 months, we worked on core recruitment, movement patterns, and increasing squat load and core strength, all integrating that underlying piston breath. We did a total of 5 C-section scar treatments. The first 2 I told you about. And then the third one, we did above and below the scar. I also added in the anterior primary rami at T11 and L1. And so that picture I showed you at the beginning with the abdominal wall, adding in along the abdominal wall there, you can target the spinal segmental level. So I did that. And then bilateral glute med, that was low frequency as well. Treatment 4 was the same as treatment 3. And then treatment 5, I added in high frequency. So I did the C-section scar on high frequency. And then also did anterior primary rami T10 and T12. And then I did do liver 3 bilaterally for some systemic input. So those were all of the electroacupuncture treatments that we did. And so what was the response to the intervention? So by the last appointment, the scar had changed a lot. Actually, I was able to lift and roll the scar. There was some mild sensitivity reported in the middle of the scar only. And I felt there was still some tension in the middle inferior aspect of the scar, but all in all had changed quite a bit. Her stress urinary incontinence improved significantly. So at this last appointment, she had attempted lifting 165 pounds, which was too much. She didn't feel great and had some leaking. But before this, she couldn't remember the last time that she leaked, where she previously was leaking when she even just went to sit down in a chair. And she had no pain down her leg, no flare-ups of her SI, J, or back pain in the 3 months that we worked together. Functionally, she was back to running with ease and wasn't having any ankle discomfort. She was comfortably squatting 140 pounds, symptom-free and feeling good. And she said that squatting felt great and her hips felt great. I do want to note that throughout our treatment together, she was undergoing a muscle biopsy in her calf. And so she had a biopsy and then she had to have like surgical rescission of part of her calf muscle. And then I went off on maternity leave. So we didn't get to progress past this point, which is kind of sucks because I think it would have been really fun to see kind of how far we could have progressed with her lifting. So yeah, over time, what changed in the plan? The frequency of treatment. So I had thought we would see each other kind of every 2 to 3 weeks, but because of the other health factors, we had some longer stretches between sessions. What stayed consistent was the electroacupuncture of the scar and progression of the piston breath and lifting. Setbacks or plateaus. Within the treatment plan itself, we didn't have any setbacks or plateaus. I think if we kept going, we would have. That often happens, but we had setbacks based on the calf muscle biopsy and then me going on maternity leave. So how do we measure progress? So we looked at symptoms, function, movement patterns, hip range of motion, and neuromotor strength, and then scar mobility and sensitivity. If I had more time, I would have definitely assessed and treated. I'm sure I assessed at some point, but we never really treated the posterior chain with acupuncture, electroacupuncture, but I do think that would have been helpful. And definitely if we would have reached a plateau, I would have been moving beyond the scars for electroacupuncture treatment, and then also treating the other scars. I didn't end up ever treating the other scars. yeah, just because we didn't have time. So what this case taught me, sometimes less is more. I would have thought that we needed more appointments, more treatment, and it would have taken longer to have changes just based on the symptoms and the history. But even with 5 sessions, there were significant changes in the scar and the person's function, which is the most important. What I would approach again, I would think I would do a lot the same. I think overall it was really positive. Ideally, I wouldn't have been leaving on maternity leave, and we could have like seen this case through to getting her lifting heavier and heavier. And that would have been fun. And I think there would have been a lot of like trial and error and learning there. And it would have been interesting to see again, like how electroacupuncture can support that. And next time, yeah, just if I treated the posterior chain, would it have been any different? And more research. So what would I like more? I would love to see research with electroacupuncture on C-section scars in particular. We do have some research on using acupuncture and electroacupuncture on scars. It's mostly case studies and small research studies, but it would be neat to see some that's specific to C-section scars, because we're still at a time where it's not even routinely recommended for physiotherapy or rehab after childbirth, let alone C-sections and abdominal surgeries. And if we have the research, it tends to be more readily adopted or recommended in the medical community. But that's also why webinars like this are great, to share what we're doing so we can help each other. That is all. Thank you. Hopefully it wasn't too boring. Too much
Thanks
talking.
very much, Micaela. We do have one question here. How would you, this is going back a little bit to the beginning of your presentation, how would you observe breathing pattern along with coordination of core musculature, especially TA?
Yeah, so I'll look at it in lots of different positions, but I'll always start in standing, because I typically will start my assessment in standing. So even just when I'm looking at their posture, I'll just observe where they're breathing without saying anything, just where their natural breath tends to go. And then when I do palpate the pelvic floor and the transverse abdominals. So if I'm palpating the pelvic floor and standing, I'll also palpate the transverse abdominals, and I'll watch their breathing pattern and then feel for excursion. Because what we should feel is that when that diaphragm descends, you get lengthening of the abdominal wall and lengthening of the pelvic floor. And then when the diaphragm comes back up on exhale, that you feel that abdominal wall tightens a bit and the pelvic floor lifts up. And so I feel for that in standing, and watch the breath. And then I'll also do that in crook lying a lot of times too. And it will be different because they're in a different position. And then you can play around with changing their alignment and see what changes. And that can give you more information too.
And why did you start with low frequency on the scar? Also, why the timeline before starting high frequency?
Yeah, I don't think I have like a solid answer, except like no, I have a solid answer, but it's more just I find both frequencies work well. So ultimately, I want to do high and low frequency on the scar, and just that the high frequency is, or sorry, the low frequency is like tolerated more well, or it's just the way I start. You could definitely start with high frequency if you have experience doing that and you want to. I just usually start with low frequency, and then I will switch to high. And I think it took a while for me to get to high frequency, just because we ended up having like much longer time between appointments sometimes. But ideally, like I would introduce it earlier, probably like the second or third time.
Did you start doing kind of pelvic floor treatments with scarring before you learned about the electroacupuncture, or have you always kind of gone into that thinking, oh, this is a great tool that I should learn about, and then added that?
So I think it went hand in hand. I was sort of learning pelvic health at the same time as I was learning electroacupuncture. And then in the McMaster Contemporary Medical Acupuncture program, I saw Alejandro do case studies where he would treat C-section scars. So it just kind of happened hand in hand that I was learning this about them both at the same time, and saw some case studies that were really impactful, and then integrated that into my care, which was about 10 years ago now. So I've been doing it for about 10 years together like that, and have seen big changes in really old scars and newer scars. So it's been really effective.
Um, Thoughts on working with an ND and combining your treatment with a retrograde injection of Tramiel or Zeal to change tissue polarity and tissue perfusion?
I don't know anything about that. Yeah, sorry.
um, so along the scar, in combination with electroacupuncture and circling the dragon technique
Yes.
around the periphery of the scar too.
Is that
I don't know if it was a question or
trying to see if I can read the question?
the last one in the Q&A.
Oh, yeah, like would I part two of the question? Oh, part two of the question. Oh, I'm not sure about the injection
Tramiel, yeah.
in combination, but in terms of electroacupuncture, I will yeah, I will circle the dragon, also thread underneath the scar. So
Right.
I will typically
Not through the scar. You're going
under. Yeah. So starting just like a little above the scar and threading underneath, and then I'll do one along. Just because I find it's tricky, the scars are quite low to thread the other way. So I'll just go perpendicular along the inferior aspect of the C-section scar. Yeah,
um,
I haven't treated anyone that's had injections for their C-section scar, so I can't comment.
right on how that works
Yeah, I
together.
like whether they just didn't like they went that route before trying acupuncture, or I haven't had anyone come after having that done. So, and I haven't referred anyone for that either.
Did this patient have a relatively fast recovery? How long would you usually expect to work with patients to progress as far as she did?
Yeah, I mean, I thought it was pretty fast, but sometimes I think like when you give the body the right stuff and you give the right person the right stuff, it can happen pretty fast. And I think this is just a case where it was a good fit. Um, I was able to fill in blanks, like gaps for her, and she just ran with it and she did it. And so I think it was quite successful. But again, we didn't like we didn't really get to finish rehab, so I don't know how she's doing now. I don't know what happened as she tried to challenge her fitness, if there was any more plateaus, but I do think she made pretty good progress. And I will say, I do find in these cases, especially the C-section scars and not having done like any kind of pelvic health piece from an external movement perspective, that when you blend the two, progress happens really quickly.
Mm. You had mentioned that she had metabolic issues like fatigue, drained by the end of the day. Did you find your treatment was able to change those symptoms?
Yeah. And again, I'm not like
You're
totally
not
sure those were
right,
metabolic. They was like hypothesizing that they were metabolic, and she definitely was able to be more active. So I think, if I'm looking back without having her here answering those questions, if I'm looking back, I suspect that her being able to participate in activity and not have pain flare ups contributed to her having better energy, because she probably had better
right,
sleep, etc. So that would be my like educated synopsis of that. Yeah, but we didn't, and she'd already done some work. She'd already like worked with a naturopath. She'd already like covered some of that stuff. So I didn't focus too much on that in our follow-ups.
right. So when with the electroacupuncture, are you trying to go across the scars? Because you had mentioned you go underneath. You're needling underneath.
Yeah, I feel like if you have the scar, I don't want to go into the scar. I'm trying to go underneath or close to it. So I'm not putting the needle in the actual physical scar. Does
Right.
that answer?
Is the current
Oh,
trying
the
to
current.
go? The current,
Oh,
yeah.
um, I don't think of it that way when I'm doing it. I think of the needles going into the connective tissue underneath the scar and in the area where there's sensitivity. And then I hook up current to every needle that I possibly can.
Right.
Yeah.
Right.
So I think of it more as like adding current to the area and the nerves
Right.
in that area.
Right. Not specifically just the scar tissue.
Correct.
How important is it to correct a diastasis recti? It's not really my area of expertise, but I've heard some pelvic health PTs mention that it isn't as important as we make it out to be. How do you manage that? When do you think it's a relevant treatment target or outcome?
Yeah. So the thing with a diastasis is a lot of them are quite normal, right? So we don't have a lot of data on like what's, so this is the change in the conversation is that a diastasis has to happen when you're pregnant. There has to be stretching that happens. And most people recover just fine afterwards without complications. But we're learning there are some people who are more at risk of having problematic diastasis. The way I look at it is it's a sign from the body. It's an area where I can look at and see how the body's behaving, and then we can do some intervention and see what changes. But it's not, the focus isn't about making the diastasis better. It just gives input to, are we getting better core connection? Like, are we getting some tension across the linea alba? Is that translating into function? How do we train that? So it's not so much that it has to be corrected, but that we do have to have functional recovery if it's even impacting it. So it's something that I will look at, but not necessarily have as a treatment goal, if that makes sense. It's a broad answer to a complex question.
Yeah, I think so somebody had asked, how is the diastasis assessment like after, regardless of the post sheath not repaired?
Yeah, I look at it the same way. Again, I'm trying to get information from the body, like how is, because we know that in order to have good stability across lumbopelvic in single leg, you have to be able to transfer load through the linea alba. And so I want to know, like, can this person transfer load, or is there breakdown in that happening? And if so, then I have to train it. And
Hmm.
so that's what I want to know when I'm looking at this. So even if there's been a repair, I still want to know, like, can they connect to their transverse abdominals? Is that generating tension across the linea alba? Is that happening when they're laying down? Is it happening when they're standing? Is it happening when they're on one leg? So I want that information to help me put together a plan that's going to help them and see, like, where is that challenge happening, which is also awesome because then we can use our electroacupuncture. Because what happens if I then do electroacupuncture on the abdominal wall and then they stand up and now they can move better? Like, then we
Hmm.
get more information. So I like to know how they're connecting to their body, and then that helps me understand like what kind of intervention we need. So I still look at it even if they've had the repair. Just the part about the posterior rectus sheath is that is important in that load transfer across the linea alba. So if that's not repaired and there's a hernia and it's not repaired, it just lets me know that some of that connective tissue integrity isn't there. So like we might max that out at some point. And so it's just like if you didn't have an ACL in your knee, like you may max out that
Right.
at some point. It's that kind of information, right? So it's not that you can't, it's just understanding that there is an actual structural, like a potentially structural
Limitation.
limitation that I'm not going to be able to change.
Did her gait improve? Like reduced hip extension, heel off cycle was reduced?
Yes.
Yeah.
Which to me is why I
Sorry.
shouldn't have ankle discomfort anymore.
Right,
It's
right,
not something we had to get into great detail. So that might be another place. Like as she, increased her running, like maybe we'd have to revisit that a bit more.
right, right. Okay, so going back to the needling around the scar, when did you place the needle under the scar? I think they're looking for a bit of more clarity, or if you could go over again, outline. And again, I don't know if this is
Right.
part of your course that you do.
Well,
There's more information in there. But yeah, they're asking how, if you could outline how you place the needles around the scar.
okay, I'm gonna go back to the picture. To one of them. Okay. So is this one? Maybe this one's better. So here's the scar right here. So this one I'm just trying to thread. So these are probably 40s or 50s. And I'm trying to thread underneath. So you can see I start like, I'm going to say it's maybe an inch away from the scar. And then I'm trying to thread underneath the scar. So inserting and then threading underneath. And then here on the top of the scar, so this is the scar here. It's kind of hard to see. So I'm threading underneath. And then on the inferior aspect, I'm just doing still like a threading technique, but perpendicular to the scar, like half an inch away from the scar. I will say this also is taught at the McMaster Contemporary Acupuncture program. We do teach how to treat scars. So that's where I learned how to do this.
Okay.
Does that help?
I think so. Why did you choose to thread longitudinally instead of horizontally? I think you do a bit of
Because
both, right?
yeah, you can do both. You definitely can. For me, I feel like the C-section scars are quite low on some people, and to thread to get enough space to thread from the inferior aspect, I just don't feel as comfortable like exposing the area as much. And I also, so that's part of it. And it's not as comfortable for needling. And so I feel like if the top part is threaded under and then the inferior aspect is perpendicular, that I am covering enough area to affect change.
Right. And I guess what you're targeting is, like you said before, about getting the as much stimulation in the area rather than it being directional.
Yep. And
Um,
the other thing with C-section scars is like some people are not comfortable with their scars being like touched or needled. It makes them uncomfortable. So then the other thing is I just want to start with something that's going to be positive, both like have a positive effect, but be a positive experience. And sometimes I'll say, okay, like we'll do the top this time, and next time I'd like to do the top and the bottom. And then sometimes we get the top done and they're like, nah, I'm good. I don't want to do the bottom. So that's also part of it, right? Is their comfort.
um, do you think that there are pros and cons of doing it either way, or this is kind of your style and what you're getting the effect
I think
that you
something
need?
is better than nothing. I think if you can thread across the top, you're going to have impact, like input, and it shows up when you have something to retest. So I think being able to do even just the top part of the scar helps more than not doing it at all.
Right, right. And were there any dietary changes during the course of care, especially with protein intake?
We didn't get into it. Also, I have to say that this person is quite knowledgeable. So they were doing a lot on their own anyways. But yeah, with like the perimenopause, sometimes the protein and carbohydrate piece is important.
I'm not sure. So going back to the needling of the scar,
Yeah.
how early would you start needling
Yeah.
the incision scar?
I get asked this a lot. I'm quite conservative. So I'm just going to put that out there. Other people will do it sooner. For me, when we're talking about a C-section scar, you have a new baby. There's a lot happening. I like the scar to be healed through and through. There's no signs of infection, that the individual is at a place in their life where they can come in for an appointment and that's manageable. So I won't do it before 3 months. Typically, it's like around 5 to 6 months, just because I find that's when they're ready to come in and start taking care of themselves that way. Um, but ultimately, it's about it being healed completely and no signs of infection. They can also be very sensitive. So even at 8 to 10 weeks, like C-section scars can be very sensitive. So I don't need to go put a needle in that. Like there's still healing that needs to happen and desensitization that happens just from like wearing clothes and moving and getting active and having better blood flow. So that's me. I'm conservative, but we don't have any like research to say like we should be doing it this time. We should not be doing it here. So you have to use your clinical judgment. But for me, I don't do it before 3 months typically.
And as you're answering that, I can appreciate how this particular type of scar would be different than like a knee scar or
Yeah.
shoulder or something like that.
Yeah. And it is like massive, and the abdominal wall was stretched out massively, and it's through 7 layers of tissue, and they're caring for a baby, and they're not sleeping, and
Yes.
there's so many hormonal changes. So like to me, it's not the first thing on the priority list at that point.
Right, right. With scar tissue needling, are we targeting dermatomal level in anterior rami, or does it also go to myotomal level?
Both.
Well, okay.
And no, it would not be scleroderma, right? Yeah.
I think there's some great questions. Does anyone else have any questions? We'll keep the question box open, but I wanted to give Micaela a chance, and for you guys, if you want to listen to some of her information about some of the courses. Um, there's one last question. Mechanically, did you ever manipulate the needles manually?
No.
Okay.
Yeah, I would say sometimes if I have this, these scars were really old, like they weren't new. Sometimes with a C-section scar, if it's the first treatment, I might use like coated needle and not do the electrotherapy part.
Mm.
And then I would maybe, depending on if some of them were irritated, manually a little bit for the first treatment. And then the next one, I get to the electrotherapy as quickly as possible.
Thank you, everyone, for your time this evening. It was great to have you, Micaela, and all your information. And we will be sure to catch everyone at the next one. Thank you.
Thank you.